Okay. Good afternoon. Good evening, everyone. Assalamu alaikum. Namaste, Sat Sri Akal. This is Dr. Noor on the final day of COVID-19 disaster management course. I'm pleased to welcome Dr. Farouk from Birmingham, and he's also an alumni from Deccan Medical College. One of the few gems, I would say. He trained in psychiatry initially following graduation from Deccan. He moved to Usmania Medical College. He did his post-graduation from there. He moved to United Kingdom. I presume he's done his initial years in central London. Then on, he moved to Birmingham. He's currently working as a consultant clinical director in dementia and frailty, and he's also the clinical lead for, and he's wearing a lot of hats actually. I mean, he's a senior lecturer. He works for the University of Aston and University of Chester. And also he's well published. Even before he moved to UK, he had like 20-25 publications. I still remember vividly someone discussing his interview initially. He went for his first job in UK. He was asked to describe about his publication, and he replied, "Which one do you want to hear?" So I hope that's the correct rumor I heard about you, Dr. Farouk. So so let's start. The floor is to you, Dr. Farouk, and we are quite keen to hear from you, because a lot of people are going through a lot of psychological impact with this COVID-19 pandemic. And I'm sure you will do the justice for this talk. Thank you very much.
Hey, thanks, Noor, for that generous introduction. Assalamu alaikum wa rahmatullahi wa barakatuhu. Good evening, everybody from India and rest of the world, I think, wherever you are listening. So this is, I think it has come quite timely, the presentation, in the sense that we are in a phase of coronavirus pandemic in which the psychological impact and burden is coming out quite clearly. A lot of people are witnessing and seeing this sort of impact becoming very clear. So what I'm going to do now is I'm going to talk to you about what you are expecting to hear from me. So I'll just check a few things from you. So if you've come here to listen and know about the recent guidelines for the depression of COVID, then unfortunately you will be disappointed. If you've come here to find out about the medical management of anxiety disorders and the impact of the COVID pandemic and the new guidelines, then unfortunately you'll be disappointed as well. If you come here to see what is the sort of how the COVID pandemic is panning out and how many people are committing suicide, the rates of suicide, then unfortunately again you will be disappointed. But if you come here to hear and listen about the enormity of this, the crisis we're in, the comprehensiveness of this, the enormous burden it has put on the number of people, individuals, families, communities, medical professions, the states, the governments, and all, and the impact of the emotional, psychological burden, and the impact on individuals as well, then you're most welcome. And this is the right platform for you. So in the beginning, Dr. Noor did say that it is putting a lot of people under pressure. That's true. And we have seen in the UK, similarly in the Middle East and in the US, everybody is seeing the same type of problems. And you'll hear some experiences of Australia as well. But in India, the situation is quite complicated. And this is a sort of peak time. We are into the crisis, and then it is going to sort of up and up for some time before it gets plateaued and starts to come down. So the learning objective I've put down today for this discussion is, if I'm able to have some sort of understanding of the psychological perspective which COVID has imparted on people, then it'll be my success. If I'm able to impart some of the aspects of the impact on the community, the psychological impact on the community of this crisis, then I'll be lucky as well. And then one of the important things I want to touch towards the end will be the healthcare professionals. So some of you are medical students, some of you may be postgraduate students, and some of you are in the front line fighting this pandemic. And if you are in the healthcare profession, then this is a time when you will have to be quite resilient and quite strong in yourself, because you are in the front line and you will face some issues yourself as well. And then if I'm able to sort of discuss wider issues of the management of psychological problems in the population, I think this is what I'll be more than happy for you to understand. So here you are, the brave soldiers of the healthcare system. So I have taken this off the social media from one of the WhatsApp messages. So you are a very sort of dedicated and frontline doctor in this, and you're carrying a very delicate pot on your top. That is the COVID-19 pandemic, and this is how and what you are dealing with on a day-to-day basis. So you are dealing with these sort of ethical issues. You are a doctor, you have to be in the front line, but also you're concerned about your family, your own health, and maybe your mom and dad who are unwell, and you are in the A&E, you are working in the respiratory ICU, you're working in the sort of the midst of the COVID patients, and every day you have to go back home. And that is a bit of a problem for you in itself. And then also the experience of the patient, it will not be always positive. Some will be very thankful to you, but some will be quite difficult, and rightly so. Sometimes they would have lost their loved ones, and they might be losing their loved ones, and they have come well into the hospital, but they're unwell, and you're facing that. You are sort of a barrage of the social media messages you're getting. So you're getting WhatsApp messages, you're getting sort of Insta, Facebook messages, your emails, all sort of problems are coming towards your way. And you have to sort of juggle around your personal life, your professional life. And these all sort of patient expectations, the bureaucracy, the governments, your personal life and social life will all put a huge amount of burden on everyone of you. And this is where you have to sort of carry the top pot without breaking it down and come out of this crisis. So we'll just slightly talk about what these type of crises will do. Sometimes so Ebola crisis, you remember that happened a few years back, and then Africans were blamed, and the discrimination was sort of rampant to blame them as responsible for that. You have H1N1 virus that spread, and then Mexicans were blamed for that virus, that you are responsible for that virus and you brought that virus to the US. There have been many influenza breakdowns that happened before in the past, and then they happen for one or the other reason in the Asian countries, and a lot of Asians have been sort of blamed for that, or accused for that sort of presentation. And now we've got COVID-19, and the portion of blame is already coming in different ways and directions. So a lot of countries are talking about China and other countries. You have heard about the WHO, you've heard about the 5G theories, you've heard about Bill Gates, and that goes on and on and on. So where are you trying to focus on your patients, trying to manage the difficult viral infection which is spread to different parts of the community? At the same time, you have to sort of tackle with the false or fake information that is coming your way, and also tease it out, which one is what is right, what is correct, and what I should forward the information, what I should absorb and take on. So all that will have an impact. So this is sort of general trends that happens when there's a huge crisis or disasters that are happening. You have to get the news out from the fake news. So how does it impact on the individual? So let you be a healthcare professional, or you are an individual in the community, or whoever you are. And as a doctor especially, you're having an issue of guilt, a bit of anger, a sense of learned helplessness. So in the beginning of the pandemic, there were no PPEs available. That happened in a country like UK, which is quite advanced. But later on, they started to pick it up. But everywhere there was a crisis of the PPEs, whether you're getting that or not. So a sense of learned helplessness will be there. There'll be anxieties, phobias, different types of panics, that whether I'm positive, what is going to happen to my family? If I'm the breadwinner of the family, what is going to happen to my family if I contract the illness? Whether I'm going to spread to my baby or to my grandfather, grandmother. Those sort of panic situations will be there. People at the stages go on from the panic, phobias, and anxiety. They might land up in a situation of depression, which can be a clinical depression that needs treatment. People are isolated, social distancing, and then sort of shielding has created a sense of sort of social isolation among people, that nobody to look after them sometimes. Loneliness and increased in the trends of suicidality has been reported. And you would have already seen the domestic abuse that has gone up, where the families and personalities can't get along together and living in the same household, and that has put a lot of pressure between the spouses and between different members of the household. there is a significant sense of loss of identity, loss of self. And then more sort of difficult ones, which are like the stressed post-traumatic stress disorder, PTSD, crisis, abandonment. So all these sort of presentations will be there whenever this sort of pandemic appears. Now, I did touch upon the issue about the fake news and false information. Now, media plays a huge role in this. Whatever way you want to look at it, media has a significant amount of impact on individuals, and then we have to be very careful when we are sort of taking the information, taking the news on what sort of information, what sort of news you're going to digest. So this is one of the Lancet journal, the recent publication about the COVID-19. So in the previous infections, like the COV1, we have a MERS infection. Now, all these infections, there are certain presentations on the mental health. Now, COVID-19, it is reported that most people, like previous infections, will recover without significant amount of mental illness. But more recent data is suggesting that things like conditions like depression, conditions like fatigue, and a sense of sort of chronic fatigue will set in some people. PTSD is being recognized for a number of reasons. Some of the rare neuropsychiatric syndromes, like I'll be talking about the ADEM, one of the encephalomyelitis, which will be affecting in people with COVID, and also delirium presentation, which is getting quite common with this. So now this is again another paper which was published in this year in May. I think this is an Indian sort of a study, and then it just comprehensively talks about the same WhatsApp picture I just showed you in the beginning of this presentation, and how we are dealing with this. So what is involved in terms of this outbreak? So it involved the government and the rules and regulations, which are quite impacting on individuals. There is a lockdown, so there is an economical and financial angle to this, which will happen in the coming months and weeks. You will see a lot of poverty, with a lot of depression coming out of that, and because of the lockdown, the people's livelihood has been lost. They have lost their sort of earnings, their savings, and then the loss, actually the life loss, the physical health and morbidity loss, which will impact on the psychological ill health as well, is an issue. And then you have this sort of acquiring of the media, presentations like this, programs like this, the webinars, the sources of information you're reading on a regular basis, but then media is giving you constant information in which you're sort of sorting out the fake news, the good information, the correct information, and then you're trying to help other people as much as yourself. And then there is, so all these have a very sort of clear impact on the individual and in general in the population and the communities. So what will happen so to the community? How will this pandemic affect? So it's a sense of morale in the community. So I'm speaking to a lot of my friends and family members who are in Hyderabad, and you might be speaking as well. You might be in touch with them as well to see how they are coping, how they are sort of getting along with this pandemic. And then general morale is quite down. People are feeling low and down. I see every so often that ICU beds are not available. There are patients waiting on oxygens at home. They are suffering, and then a lot of things can't be done for them. So all these things will have an impact on the morale of the people in general. And then it's a sense of also a fear psychosis. So you saw the initial bit of the pandemic in which a lot of conspiracy theories have been put forward to. Many of them now has been sort of either dismantled or has gone in the background. Now, I have approached this with this idea. If somebody's talking about the conspiracy theories, that's fine, absolutely fine. People can have their own ideas and thoughts. But currently, what we know with the amount of evidence we have got is this is a viral infection and it is causing destruction of life. And we have to try and save and protect as much as we can. So this is how we need to take this as to avoid the fear psychosis developing. Fake information and information overload, I've touched it again. Media and gossip. Again, this is something that comes along. A lot of people do talk about it. A lot of people share that information, and then you get frustrated. You get angry that this is wrong information being spread. But how do I control? That's again in your mind and your brain. Amount of guilt sets in as well. As a health professional, that whether I should go to my job or not, whether I should go to the medical school or not. Should I be going to see patients? Should I open my outpatient clinic? Should I attend the A&E? So all these things will put a sense of guilt because you're a doctor. Your role is to help people, but then the viral infection is causing you sort of a sense of fear. For example, I'll acquire it, or my family can acquire it. So that's why I want to protect myself and my family. So that again creates a sense of guilt. Domestic abuse cases have gone up, as I just touched with you. Suicidal behavior has increased, and there are a number of people we are seeing in the UK as well who are feeling suicidal. A hopelessness and worthlessness is setting in people. Now, briefly touch upon some of the stages of grief. So people go through the stages of grief, and you sometimes when you're working the front line, especially when you are working on the RICU type of places where you are seeing the COVID patients die on a regular basis, then you have to take care of yourself and your health and just be aware of these sort of things. So there is something called as denial and isolation. So first of all, said this is not a pandemic. So there are a lot of world leaders who have denied this pandemic at the beginning of January and February. You would have seen that a lot of world leaders have said that this is nothing and they're going to go away. But then the reality sets in. Then anger sets in because you've sort of come to terms with something which you're not able to deal with. It is something quite enormous, and that anger sets in. And then you have a bargain, whether it is conspiracy theory, whether this is something else, it is not a viral infection, it'll go away, that sort of bargaining. And then as the time goes by, a low feeling sets in, which causes depression to people. And then at the end, a lot of people do accept that this is the reality, and then we have to go through. Now, generally in the community, there are two sort of sets of symptoms divided into short-term and the long-term psychological presentations. Now, you will be seeing, some of you who are working in the front line will be seeing these on the general practice on a regular basis, and this is gone. So stress reactions, so acute stress reaction, which can present sometimes in a psychotic type of episode. But then anxiety, panic, and anticipatory anxiety. That is something unknown future. What is going to happen in the future? Am I going to have problems with this, whether I'm going to resolve this or not for my patients and for myself as well? Then due to lockdown, loneliness and isolation has caused a huge amount of problem for people. And then you're seeing the second lockdown comes in, and the same set of things are repeated again. There is a fear as well. So fear and phobia of one, acquiring the virus, but then second is also spreading it to our family. And if there's a loss of life, what will happen? Information overload, we've talked about. Bewilderment, that not being very clear, being confused and muddled of the situation. You're getting sources of information. WHO has been challenged day in and day out on a regular basis. They're right or wrong. They're giving misinformation. They're providing correct information. What about the hydroxychloroquine, whether it should be used or not? One country says yes, the other country says no. So all these sort of things will cause bewilderment in people and also in health professionals as well. Domestic violence we talked about. There is lack of support and care, which was there. The mechanisms of people meeting with each other, talking in congregational places. A lot of places like mosques and temples, people used to go to pray and have their time. That is all cut down, and that has had an impact on the social life of people as well. In the longer term, you'll have presentations like depression, which is something, clinical depression is something a lot of people will experience and have started to show symptoms. There is also a sense of loss. So there is a loss of either an identity, there is a loss of people, losing people, their family and loved ones. Post-traumatic stress disorder. This is something that happens further down the line of the disasters and these pandemics and crisis situations, when people suffer from the PTSD, and that the symptoms can be varied from sort of psychotic anxiety presentation to suicidal behaviors. So there's a range of symptoms PTSD can present with. Now, due to lockdowns, people have faced the economic crisis. Now, again, the enormity of that is just beginning.
Sir, you have 5 minutes left.
Okay, yeah, thanks, Naveen. So I think I'll sort of skip some of the slides, and I think I'll come to some of the healthcare professional side of things, which are important, I think. So learn helplessness.
10 minutes, Dr. Farooq. You can have 10 minutes, no problem.
Okay, thanks, Noor. Thanks for that. Okay, so some of the things like, the learned helplessness and apathy, for example, people will experience as well. And I would go into the learned helplessness, but that's for another day. It's quite an interesting concept. If you look in some of the books, you'll find it. Now, corona positive and quarantine has made people lonely, and they have faced the isolation, the anxiety symptoms, which can present with the restlessness, agitation, pacing up and down, getting the palpitations, sweating, trembling of hands and legs. So it can have physical and psychological symptoms of presentation. So when somebody has tested positive, so we had a helpline, the psych support helpline, which is providing support some people on that. So what we are finding is, as they have come positive, irrespective of whether they have developed any symptoms of shortness of breath, the SATs are really good, 96, 97, 98%, but still they're feeling quite panicky and anxious at what is going to happen. So again, this is anticipatory anxiety a lot of people will have. A panic situation, PTSD we have touched upon, depression will be there, again, the effects of quarantine. Now, what is the sort of management, what you're going to do? So providing those people on the helplines or on the phone with appropriate and accurate information about the condition, and asking them, being tested positive doesn't mean end of it. So you've been tested positive, but what are the symptoms and what can be done? And there's a protocol which Dr. Athar is going to talk about, I think, in terms of how and what sort of things you can do at home. That gives a beautiful description of what you can do. Providing the therapy, counseling on the phone, that is one of the ways, or the video call, that is another way to provide support to the patients who are having this anxiety and panic situations. Mental state examination of patients who have been isolated or quarantined for some time, because they might feel isolation and loneliness, and people who are long-term hospitalized, it'll be important to check their mental state examination, what they're going through. And then you can do some of the psychotherapeutic assessments to come to HADS, and for the anxiety, and there is also for the depression, Hamilton's rating scale for depression as well. You can use that. In the future, there must be some mechanism of following that up in the future to see what's the impact of that. Now, I've divided that into the children and the older adults. So generally in adults we've talked about, but in children there's a specific type of presentation now, which is impacting on the psychology. The boredom, there is no stimulation at home. Sometimes the timetable is completely gone out of the window. So they used to get up in the morning, go to school, come back at 3, 4 o'clock, and you have a tuition for them. And all those sort of regularities, sleeping time, getting up time is completely gone. So that discipline has been lost. That has impacted and will impact on their education development if not paid full attention. Anxiety of uncertainty. So what is going to happen? What's going to happen, mom? What is going to happen to me, dad? Is the school going to open? What happened to my friend? What happened to my friend's family? If they're unwell, if they're not doing well. So how things are progressing. So this is the anxiety of uncertainty. There are developmental issues. We will see in the future, there's been sort of suggestion of the impact of COVID still under sort of research. We will not know until the pandemic grows further. And there is infection phobia. If we go out, we'll contract the infection. So how are you going to manage them in children? So I'll just skip through these slides. So it's a responsibility of parents, having a supervision or a constant supervision of them, having them schedule and structure in the day, and provide them with online material. And then the studies should be quite well sort of framed into a timetable on a daily basis. An open and frank discussion with them about the pandemic, not to say that you don't know about it. Children know a lot, and with the social media, they are knowing a lot in huge amounts, and sometimes they share the information with us, which is surprising that how did they know? So they know more than what you think. So share the information with them in a positive manner, and then talk to them about the hygiene and precautions to be taken. And older adults, again, this is something which is getting quite sort of well known. Irritability, anger, fear, so phobias, anxiety, will be all be the same. But then cognitive decline, that has been also seen in some people. It has been affected. Stages of bereavement, I've talked to you about the stages of grief, which will be similar in older adults. When they'll be having the regular routine checkup of their cardiovascular system, of their neurological system, diabetes, that has all come to an end. So the support system they have, medical support system, their essential support system, getting their medicines, getting their social contacts, that all has been impacted. So that has to be taken into account for their psychological impact, how it is affecting. So many of them can't travel. They're dependent on the children or the family members to take them out, take them along, and that has been missing for some time. And they might feel that COVID is affecting over 60, over 70. So we are the burden of society. We are the ones who are going to be killed first. So in the West, if you see in the UK, most people who died are over 80 years of age. Care homes, nursing home population has been sort of, many of them have died. and they might think that we are a burden on the society. So that need to be taken into account. And one of the things which we are seeing more is the delirium, and then I'm going to touch about delirium briefly. So this is what all you can do: online consultations and video consultations for this group of people who are quite vulnerable. And then you have got some supportive psychotherapy you can offer to them via the phones or the video conferencing, and the family support, which can't be sort of replaced. So delirium management, I think this is one area which is becoming more and more, and you will hear more and more in the research in the coming days. The presentation is similar, but there are slight differences. There is more of agitated and restlessness present. So agitated delirium is there. So it's not sort of the quiet delirium, it's more active delirium in the presentation. People have got mood changes in the presentation. They got the delusional beliefs. Sometimes they are hallucinating as well. And then moving around in the wards, pulling out the cannula and pulling out their sort of all the Riles tubes and all those sort of gadgets they're having all around. They're trying to pull them off. So this is quite an acute onset, but it is fluctuating as well. There is a disturbance of sleep-wake cycle. You need to perform a full physical examination for these people and a profile of investigation, which is there. You can check on the slides, the set of routine investigation. And then you consider CT scan if it is indicated, get the CT scan done. Now, review the current medications. Many a times delirium is impacted by a plethora of different medications being prescribed, and they come to the hospital and then you have a new set of medications started. So have a look at that. Common things like constipation needs to be treated. Appropriate and proper hydration of them. In the summer times, they might not be having that sort of need to look out for them. And then do not try to challenge their delusional beliefs, because delusional beliefs are not their ideas and thoughts and fancies. That is coming from their brain. The mind is telling them to believe in the demons. They're seeing the demons. They're having the persecuted delusions that you as a doctor have come to kill him. So you need to be careful when you're assessing those sort of psychotic phenomena. Do not challenge them, but try to work through with them, inform and educate them. So what you're going to Yeah, okay, I'm going to come to an end. So lorazepam and haloperidol has been suggested, but in some people who have got the very psychotic presentation, risperidone has been sort of used as well, but haloperidol and lorazepam has been talked about. In very severe cases, you might have to use the combination of that. In some people, a combination of both lorazepam and haloperidol, but there is risk of respiratory depression, and ECG needs to be done before you consider that medication. And this is some of the dosage of the medication. I'll just go through one of the things I want to touch upon is the neuropsychiatric presentation. And this is, I think, one of the important areas to know: the acute disseminated encephalomyelitis. There is a hemorrhage in the brain, necrosis, the death of the brain cells, and the myelitis are the common presentations in a group of people. So there have been reports, it's just been published in the Brain Journal, that these are the presentations that are happening. So this is the July, just day before yesterday, this article was published. You can have a look through to look at ADEM presentation, which is a new presentation in COVID patients, and you will hear more as the research continues in this area. And then what you do in general management: antidepressants, anxiolytics medication, benzodiazepines. Be very careful, because you're treating also the respiratory depression. So when you prescribe the benzodiazepine, it can cause central respiratory depression. So you have to be careful on that. You can use antipsychotics and mood stabilizers as well. Now, I thought I'll touch upon this, I think, briefly, because this is something you all on the front line. You are the soldiers fighting this virus, this pandemic, and you have to look after yourself as well. All these presentations, you can have a look. Many of you, I'm sure, who are in the front line are facing this: worthlessness, guilt, a huge amount of pressures. You're doing day in and day out. Your colleagues might not be turning for work, and they are in a lot of difficulties. They are not well, probably, and you are thinking you might be not well next week. So all these sort of things, burnouts are huge amounts, and the learned helplessness.
So you have 5 minutes left.
Yeah, okay. So just touch upon what you can do as a group of medical fraternity. Try to support each other. If there is support from the government, avail that support from the government. I'm hearing that a lot of government hospital like Gandhi is open, but a lot of people are not going there. Maybe the situation is different there, but try to avail that opportunity and supporting your colleagues, mutual support among yourselves, joining hands with voluntary organizations. DA is doing a lot of things, DAME, the Helping Hands, and DARE, those sort of organizations. Try to work with them and see whether you can work together, and then mobilize resources from different areas. So this is just to skim through of some of the psychological impacts of the COVID pandemic. That includes the children, adults, older adults, and healthcare professionals. I'll shut up now, but I'll take some questions if there are. We're doing now.
Thank you, Dr. Farooq. Sorry, I think we cannot let you have similar time what you spend with your patients. I presume you spend like 1 hour with each patient. I'm afraid in the interest of time, can I move forward? We'll take the questions at the end of the seminar.
Yeah.
Your talk has generated a lot of questions, I'm telling you. I mean, the questions of hypochondriasis, depression, anxiety, and medications. Wow, this it has generated a lot of questions. Moving on, can I request one of the panelists, fellow panelists, to introduce Dr. Abdul Aziz Khan, the next speaker? I happen not to work with him, but I presume one of you members have known him personally, so I would request you to introduce him as he's preparing his talk. Naveen, can you share his...
Abdullah Junaid.
Yes. Assalamu alaikum.
Walaikum salam.
Join Dr. Aziz Khan is with us.
Yeah, he is there.
Dr. Aziz Khan is there, yes.
I welcome Dr. Aziz Khan. He's basically oncologist working in a hospital. So he's the one who has given insight to me. What about the death patients, Dr. Saeed? Who is taking care of the death patients? Because in India, death patients with COVID is not respected. They are just dumped in the graveyards. So you are just giving me a thought almost 3 months before what to do, how to proceed. Then we inquire about this, how to deal with COVID death patient in Saudi Arabia. Then we find different steps. Inshallah, we'll be talking about this. So, mashallah, we give an insight to us how to approach death patient in India. Dr. Aziz Khan, I welcome you.
Yeah, assalamu alaikum. This is I'm joining for the first time. I was not knowing this is such a professional meeting. So I really appreciate the efforts and the way you people are exerting a lot. I hope it will affect at the gross level, root level, where people are really suffering a lot during this pandemic. So my topic is totally different. This is after the death of the victim of COVID patient, how to deal and how they are being dealt up to now. It is sometimes very horrible pictures are coming in the media. I'm sure you all are aware of those things. So this was the reason we thought better to make the public aware about the medical issues, how serious is this one, and then correlate with the Islamic issues, what the Sharia they say about such issues. So I will share with you a few slides. How to upload the slides, Dr. Umar?
You have to link. You have to click on the screen share screen. There's a green icon at the bottom of the.
Yeah.
If you can click on the share screen section.
Yes, there you are.
Yeah. So basically, I chose two things. One is first from the medical point of view, and we look for the guidelines that how the dead body of a COVID victim should be dealt and what are the risks of transmitting infection from such a body. So I have two references. One is from the WHO, that was this infection prevention and control for the safe management of a dead body in the context of COVID-19 interim guidance, which was issued in March 2020. And the other one is this one, considering related to the safe handling of the bodies of the deceased person with suspected COVID or confirmed COVID. This is from the public health authorities of the EU member states and the UK. So these are my sources for all these information. So when we reviewed these two guidelines, they divided the dead body in three categories. And the first category, this is basically covering all the dead bodies, whether they are infected or not infected, or whether they died because of some other diseases, but they put in this category one, and this is very low risk of transmitting any infection from such dead bodies. The second category is very important for us. This is, in this category, they included these diseases and they put this as a moderate risk for transmitting infection. So in this, they included HIV, hepatitis C, Creutzfeldt-Jakob disease, severe acute respiratory syndrome, avian influenza, Middle East respiratory syndrome, and our concern is the COVID-19. So the COVID-19, they included in the category 2. This category means there is a moderate risk of transmitting infection from the dead body to the close contact. And the close contact for us is the people who are doing tadfeen right from the ghusl and then kafan and all these things. So here is the moderate risk of transmitting such infection, not the highly infectious, as most of the time the people they perceive to be. The third category is highly infectious. And the diseases in this category, they are really the maximum chances of transmitting infection from the dead body, and the maximum precaution should be observed during handling of such dead bodies. And in this category, as you see, anthrax, plague, rabies, viral hemorrhagic fevers, and this Creutzfeldt-Jakob disease with necropsy, they included here also. So this is not our concern. We are in the category 2, where there is a moderate risk of such infection. So here, this is a very important slide. What they are saying that the handling the dead bodies of the person with suspected or confirmed COVID-19, and there is no evidence so far for the transmission of SARS-CoV through handling of dead bodies of the diseased person. However, the potential risk of transmission related to handling of such bodies of diseased person with suspected or confirmed COVID-19 is considered low or moderate, the way they categorize initially in the category 2. So the important point here is, up to even today, around 5.4 lakh people have died because of the COVID-19. And there is no evidence of a single case of transmitting infection from the handling of the dead bodies to those people who are handling them so closely. There is no evidence. So whatever the evidence is, the risk of transmitting the infection from this such dead bodies is either direct contact with the dead body, or its fluids, or whatever that is coming out from their body, or the indirect contact, mean the contact with the fomites, like the other they are transporting and all these things. They are also included. There may be a chance of getting infection from them. Here, as initially we all know that the SARS-CoV can present on the fomites for a few days only. So they say, and this is the reason they put in that this may be the risk for transmitting infection. Therefore, unnecessary contact with bodies should be minimized by those not wearing the personal protective equipment. So this is their guideline, that the personal protective equipment should be there while we are handling these dead bodies during our religious things. And those in direct contact with the diseased cases of the COVID-19, both suspected and confirmed, should be protected from exposure to infected body fluids, contaminated objects, or other contaminated environmental surfaces through wearing appropriate PPE. And the minimum, they say, either they should be gloves, a long sleeve gown, waterproof, and the mask. These things are the minimum that the person should have these while dealing with such dead bodies. Now, the standard, during standard handling, the risk associated with transmission is usually by the droplet infection, they say, which we know the airborne infection, and especially when dealing with the dead body during ghusl. So they say it should be avoided to have a throwing water and just creating aerosols, and this may be the source for transmitting infection. But this can be overcome by wearing the personal protective equipment, and we know by wearing the at least N95 mask and facial shield. they should be wore during this procedure. So in this slide, what they are saying that the professional group within and outside the healthcare system that are involved in handling these dead bodies, they should issue the guidelines to a particular area. And besides healthcare staff, this could include primary, mortuary staff and funeral agencies to coordinate the funeral of such dead bodies. And the more important, the stress here is the use of appropriate personal protective equipment. No, here the important another point they pointed out that yeah, anything?
No, carry on, carry on.
Yeah. In this slide, the important another important. I think my voice is clear.
Yes, it is. Yes.
Yeah. In this slide, they pointed out another important point that the victim of the COVID-19, we know most of the time when they desaturate and they need oxygenation and this thing, they usually admitted in hospital, and for weeks and sometimes for months together, they are in the hospital. And unfortunately, if they die, and so after that, this is a desire of the close family members that they should have at least at the last time to see these dead bodies. So these guidelines, they consider this aspect also, that they can, the minimum requirement include this, as I said, gloves and this gown. And viewing the dead body for mourners can be performed if mourners are religious representative or to touch the body. Standard precaution and PE preventing transmission through direct contact should be used. And minimum requirement, as I said, at least gloves, gown, full sleeves, and mask. And the staff need to ensure that mourners receive support and other moral support in this way. So this is the very important point in this guideline, that if they just see, they don't touch, then there is no risk of that infection. But if they want to touch, then they can even touch such dead bodies, but after wearing the personal protective equipment. Then this is the last slide of medical guideline, that the patient who are confirmed or suspected COVID can have cremated as usual. So this is a very important slide, that there is no need to be panic.
You have 5 minutes left.
With these type of dead bodies. So after this, these are few slides which will cover the Sharia point of view for such body, such rituals. So according to this Islamic tradition, we know the tadfeen is a farz kifaya. So this is the right of the dead body, and it is the responsibility of the people in that locality to do the ghusl and then the salatul janaza for such dead bodies. And we know this farz kifaya means even if the few people from that locality, they will do these rituals, the whole community from that is free from this farz. But if nobody is doing this, then all are answerable before Allah subhanahu wa ta'ala for not doing this thing. So in this, especially another problem in handling such is that many people, especially in the non-Muslim majority states, they sometimes, because out of the fear, they avoid doing the usual Islamic way of burying the dead body, and they sometimes do other many things. And these Islamic scholars and many fatwa, they strongly condemn such things, that this is the right of a Muslim to be buried as per the Islamic law. So I have only 2-3 minutes.
Yes, sir. You have 3 minutes left.
Okay, so I will skip this slide. This is also covering this two things, ghusl and then kafan. So in short, this Islamic, this fatwa, they say that if the dead body is not covered, and then the people who are trained in using the personal protective equipment, they can do the ghusl as usual, like any other dead body, taking precautions. But if most of the time we have seen that the hospital, they give the dead body wrapped in a paper, in this thing sheet. So these fatwa, they say that they can do the ghusl over this sheet, and then make the coffin. Usually as 3 sheet, they should be use 3 sheets to cover the dead body. And if even they cannot do that, they can use a single sheet to cover the dead body. But this is again, because they are the religious scholar, they don't know. They say it should be according to the guideline for the local health authorities if they permit to do like that. And if they don't permit, then they can just throw the water just over the dead body, the wrapped in the sheet, and then put the coffin. And at the last, if they say if they cannot do this thing also because of this guideline, they just spray water over the dead body and put the coffin. And if they cannot do that also, then they are of the opinion that even if the tayammum can be done over the dead body. And the extreme is that if they cannot allow to do the tayammum, then such dead bodies can be buried even without ghusl and without coffin. But this usually they gave the reference to the large number of casualties in civil war in Algeria and Tunisia, when there was at a time many dead bodies and they have to deal with such. This is reference to those situations. But in this today's situation, I think most of the time it can be done without any problem. And then after ghusl, the
Sir, you
coffin,
are
as
running
I
out of the
told
time,
you,
sir.
we have to do this thing. And the last is Salatul Janaza. Salatul Janaza, there is absolutely no risk in praying for Salatul Janaza in such patient. We know we are maintaining the social distancing, and in Salatul Janaza, there is no such, nobody is going to touch the dead body. And they have to observe the social distancing and they can do the Salatul Janaza. But according to this fatwa, if there is a problem, at least 2 people should be there to pray for this dead body, and it can be done even at the place of burying, at the Qabristan, they can do it. And in the extreme end, even Ghaibana Salatul Janaza can be done if you cannot pray during the this thing. And these fatwas are issued by the Dr. Ahmad Tayyib and Dr. Shoki Alam, the Grand Mufti of Egypt. And another fatwa is from the Jordanian Fatwa Board. So these are the 2 fatwas which I took this thing from them. So this last slide, I think the World Health Organization guidance on the infection prevention and control for the safe management of dead bodies in the context of COVID-19 shines a clear light on the debate, stating that to date there is no evidence of person having become infected from exposure to the bodies of person who died from COVID-19. However, low risk, as I discussed, moderate risk is there. So I hope we will be able to dispose of this fear and the misconception about dealing with the religious rituals with such dead bodies. And thank you very much for giving me the time to have this shared with you, these slides.
Thank you,
Thank
Dr.
you very much.
Thank you very much for covering such a sensitive topic. I think every human being deserves a dignified burial, irrespective of their faith, caste, and creed. Thank you very much. We're much obliged for.
Just
Sorry,
1 minute. Can I talk some for 1 minute?
Please.
Yeah. So regarding this issue, what we experience in Saudi Arabia, what they're doing, they are giving this body part in a mortuary. Okay. After giving body part in mortuary, they cover the body in 3 layers. Then they call the family to see the dead bodies, and even they can allow to take photos and pictures. Then they carry this body by special ambulance to the graveyard. In the graveyard, they're doing this salah, janaza. Then they hand over the body to their family members, only individual members, 3 or 4 members. Then they bury the body. So they see the respect to what they are giving. They are giving the body part, they are giving to the family, and they are hand over the body to family. So what this message is for the back in home in India. So they panic about this COVID disease spread, but dead bodies should be removed, and the doctor should have a talk to the NGOs and come forward to solve the issues, because dead bodies should be respected as the other bodies. Dead bodies with COVID has a right to be respected as other COVID bodies. So whatever the panic in India is such, I heard even a patient die of the heart attack. The people not going to janaza, even that what you call this dead body cage. Please, doctor should have get awareness among NGOs about these issues. Otherwise, will be questionable, because these of course, public has a phobia about this issue. So please try to make awareness. This, as a WK they will transportation from the dead body is minimal. Of course, you have to take precautions. Please try to respect the dead bodies and try to get awareness among the NGOs for these issues. Thank you so much.
Yeah, even I attended one funeral, and as you mentioned, after the patient dies, the body is taken to the mortuary, and they give professional, respectable body wash, ghusl, and they keep in the ref, and they call the family at a particular time. Once the family members come, they show the face, and when I saw the face, it was, the kafan, it was like 3 layers. So the outer layer is a white cloth, the inner was double thick layered with plastic, and the another inner layer. So it was, I mean, the chances of, if anyone thinks that this can be transmittable, but whereas there are very, very less chances of transmission there. But still, the body is covered well in 3 layers, multiple layers. And once the family has seen the face and you have taken photos, the body is covered. Once it is covered, it is not opened again till it is buried. So, as Dr. Bedullah said, the special vehicle comes where the bodies are carried in a respectable manner to the graveyard. In the graveyard, there are employees there in the graveyard who take care of all these things. And before burying, prayer is offered there, janaza, salatul janaza, and then in presence of the relatives, the body is handled by the employees of that graveyard in their professional manner. Even they are covered with the PPE. I mean, the gloves and the mask, and their uniforms are different, which are thick layered cloth, made of thick layered cloth, and they are, even they are protected themselves. And then the burial is done in the presence of the family. So this is how it is over here.
Thank you, Dr. Zubair.
Can I have 1 minute?
Yes, please.
Yeah, our problem is not in the kingdom. Kingdom, we know even all the arrangements are there. Our main focus is back at home. And we know there how the dead bodies are being disrespected. And I have seen many times even people, they will protest to bury the dead body in their nearby Kabristan. They will avoid, they protested, violent protest. So our main focus is back at home. Here, alhamdulillah, everybody knows their rights and everything. They know everything, and the system is very nice. But back home, it is horrible situation. So this is our main focus there. And there I feel there is two aspects to deal with this problem. One, our religious people, they should have a volunteer, train them in the basic Sharia rules to have a ghusl and kafan. And then on the medical fraternity, if they teach such volunteer to use the personal protective equipment, and then they can do everything very nicely without any risk of infection. And as I told you in these guidelines, up to now, there is not even a single case which is reported that there is a transmission of infection from the dead body to the close handlers. Thank you very much.
Thank you, Dr. Abdulaziz. That's a very, very important message to the community, medical community, that there is no infection. There's no cross-infection from the dead bodies to the handlers. Thank you very much. Moving on, the next speaker I want to introduce is Dr. Muhammad Athar. He's a consultant emergency physician. He's an alumni from Deccan Medical College. He's currently working as a physician in University of Melbourne. He's also involved with the Australian and UK Research Council. He's a health commander, and he's also a pre-hospital care physician. Dr. Athar, I like your background. I mean, it shows that you are in the city of Melbourne. Welcome to the webinar. And I just want to also inform you that Dr. Athar has been instrumental in drafting this guideline, which you can see on his screen share, home-based management of suspected COVID cases, which he's going to talk about. It's such an important topic because, most of the people, as we know, are asymptomatic or mild symptomatic, and it's optimal care, optimal advice, counseling is such a huge thing because this panic set out in the city at the moment. And these guidelines, which he has helped in formulating, will go a long way in dealing with such issues. Welcome, Dr. Athar.
Thank you very much, Dr. Noor. I really appreciate and humble with the gesture, and thank you very much, everyone, for being allowing me to be part of here. Okay. Sorry, just kind of looking. Okay, so I hope my voice is very clear.
Yeah.
Good. Okay, so it's this is one of those kind of like protocol or kind of management we have developed, especially the Deccan alumni, and I happen to be part of it, and I have had support from some amazing people there, and to kind of produce this concept. So the question for us to have a protocol for a home-based management approach, the first question came from a lot of compassionate people, including the organizers of this webinar, was what can we do back in India? And so that's from where the discussion started. And we have actually kind of taken the approach, which is a major instrument medical management and seen principles, which kind of, again, we all draw lots from battlefield medicine right from the Napoleon Wars. So the question, what happens is, like, we all have finite resource. Resource is never infinite. So you all have finite resource. And if you use a resource, you exhaust. So the question then happened is, okay, what can we do with our finite resource to help help the maximum people and make the best use of the available resources and have the major impact? Say that's where it came. Say it's, you all have already learned about medicine and the COVID and the impacts and everything. I'm not talking about medicine here. What all I'm talking about is how we can incorporate that knowledge that you had using a simple kind of a logarithmic approach. Say that's what the reason, one of the reasons we actually follow in pre-hospital world is a very simple approach. It's yes and no. It's a binary approach. The binary approach, the advantage of binary approaches is because it kind of takes away the human cognitive decision-making ability. So generally, doctors, we're very rubbish about it, because what happens is we are actually kind of put in a corner and ask a question. Hey, what do you want to do? No, we want a history. We want physical examination. We want that information before. So it's not the same. So hence what happens is take that away, give them a two option, yes or no. Yes, we may be wrong. We learn from it, but don't do anything at that moment. And we just kind of move on. Say, hence what happened is what we thought is, okay, so we all know 80% of the patients don't require hospitalization. 20% requires hospitalization. Of the 20% who intervention needed, the people who are over 60s, unfortunately, diabetes, but a percentage of them actually requiring intensive care, but other ones actually could be managed in the simple ward. So we kind of, once it's a hospital based, we're not touching that group. We are touching this 80% of these people who could be safely managed at home. So that's when we came up with this guideline. So again, we all know about 30 to 40% are completely asymptomatic guys. We don't have to do anything about them. So it's a symptomatic COVID patients who we could help them in the home environment. Hence, they could be adequately managed and trying to prevent that burden of hospitalization. So it's a financial burden as well as the burden to the healthcare systems. So our objective is, it's pretty much saying, can I provide that support to the home-based management and optimize this home-based intervention to an extent we kind of limit, or we kind of try to kind of prevent as much hospitalization as we can. And again, supporting the families for the guidance on quarantine and other issues, and identify the people who are in and under our radar, to identify who is deteriorating and who need to be taken to the hospital facility. So our inclusion criteria is pretty big. So because we want to kind of take as many people as we can. So it's anybody, basically any respiratory illness, frequent travelers, close contacts, we just included everybody. The exclusion criteria that we had was only one thing in mind: to minimize the risk. We cannot take the risk away completely. There is always the risk, but we wanted to minimize the risk because we all have seen during the COVID times, people with having other medical illnesses have actually delayed to seek help, thinking it's all COVID related. So those are the groups actually we kind of wanted to avoid. Say we thought about the fever, simple not responding to simple antibiotics. If the patient is too breathless that he cannot finish a sentence. So this is kind of for a layman to kind of not the medical personnel. So just say, okay, hang on, you need to go to the hospital. Any chest pains, abdo pains, and any other concomitant illnesses. We had a 3-tier system. The first tier system is a non-medical office-based system. These guys actually just receive the call. And again, they just only answer yes and no. And especially in the first, this row, we don't want to put medical people, because if you put medical people, they start asking questions. There's not time to asking questions. This is the time of brutal triage, yes or no. Good. They actually kind of, I'll share the appendices, which is in the bottom, which is towards the end. They actually do a triage form, and once they think this patient is actually kind of meets our criteria that we can actually help them, they pass that on to the first line medical officers. The first line medical officers goes to the triage firm, ensure eligibility, make a contact, and that would be either a teleconsultation or a video consultation, and they start the process of appropriate investigation. So the project is basically they are doing a categorization of severity of illness that individual patient has. And once that is done, and if they will come to a point that they need some help, there is a senior doctors available for them to help. Then we had an amazing group of healthy volunteers who actually became our runners. The runners these are the frontline non-medical staff who would kind of help with the patient picking up the oxygen, getting to the investigations. So it's a very nicely coordinated approach. That's kind of staffing. Other thing what we try to do is say we initially kind of had our all resources, set up our call center and all the resource bases, try to secure some oxygen cylinders so that we can actually use that oxygen supply. Have done some training sessions, the initial training sessions, and there are continuing training sessions and evaluating how the impact is. The COVID pack has been quite useful. So whenever we feel patient actually in that radar who would benefit from the COVID pack, they get this. So the people who can afford, they will pay. The people who can't afford, they just get this pack. The pack has a infrared thermometer, SpO2 monitor. That's the two big things. Because we don't want to have blood pressure monitoring. We don't want to have any other monitoring. Simple monitoring, so that anybody could do from their home with little guidance, and the runners are helping the patients and their families with this. A couple of gowns, one for the patient, one for the family member who's attending them, some simple N95 masks and all if the patient needs to actually get out of their home environment for any investigations. Okay, so I'll just come to the appendix 1. So this is the appendix 1, which has the triage details. So it just asks simple things. What do you have? And are you suitable enough here to be managed at home? If not, they will be advised to go to any appropriate inpatient facility. Then from a medical legal perspective, this is just a disclaimer that people have to actually sign it off, saying that we are advising them to manage their condition in their home environment to the best of our abilities with the remote consultation. And however, whenever we feel that you kind of need in hospital management, that's kind of the duty falls onto you. Again, this is a help that we can offer. We can't and this is a quarantine information which was developed thanks to Dr. Purvis for his meticulous work. this is once we feel actually the patient actually in the radar, that all patients actually get this quarantine information. So there is quarantine information for the patient as well as for the family members, what they can do, what they cannot do, and how they manage. I'll come to the main kind of the elephant in the room. So this is the treatment algorithm that we have. So what we find is the first group of doctors, when they actually see, okay, these patients are actually eligible for home-based management, we could actually provide them the logistics support as well as the medical management input. So it asks the two questions: is this person short of breath or not? No, that's it. We're categorizing them into mild cases. Generally, these guys don't need anything. So they get better. So we said, okay, just a bit of supportive treatment. One of the things that was highlighted was in India, it would be a hard task if we say, you don't need any medications. Because people would start kind of doctor shopping and they would kind of not be complicit or wouldn't be happy with that. So we just thought, okay, we just kind of do a bit of supportive management. So we have a drug formulary, which is another appendix. So for mild cases, we said, okay, we're going to prescribe something for you. But the main advice is the quarantine advice for the family members and the patient. And we just keep them in the radar and we tell them, encourage them to contact us if the situation changes. So some of these patients are not breathless, but we have actually taken a subset, a group of these people saying, hey, if you're over 60 and you have some comorbidities. So the comorbidities are actually kind of talked about in the bottom. So we're saying is diabetes, hypertension, previous strokes, active cancers, liver diseases, smoker, ex-smoker, any advanced CKD, or the patient are on dialysis, morbid obesity, any of these things. So if 1 or 2 over 60, we say, okay, we don't want to take them as a mild. We want to be keeping a close eye. So they come into the second group, the yes group. So yes group, we're going to give them a COVID kit, which we have already talked about what the COVID kit has. And we're going to start with appropriate investigation. There is a list of investigations for the junior doctors to kind of start that process going. And there's a supportive treatment that we already started, the basic one. The quarantine advice, and we try to collect the results. Now that comes with our SpO2 monitor. If they're more than 92% saturations, we're saying is, okay, you are a bit concerning, but you don't require any oxygen right now at this moment. But we want to tell them you may require. So if they're over 94, generally you don't need. And we just do the medical management for you guys. But if it's 90 to 94, it depends upon, you understand, kind of forewarn these people. The situations can get worse. You may be requiring oxygen. I'm not going to start your oxygen right now. We'll wait a little longer. We have added some more treatments here, and these are the evidence-based treatments as you have actually gone through during the 4 days. If situation allows, mostly the focus is to start an oral dex and azithromycin, and if there is a possibility that we could actually get home remdesivir. Again, not for everybody, but if there is a possibility, we try to aim for that. The guys who are actually less than 92 saturations, this is the guys we need to be very careful. If over 60 and if they have comorbidities, or under 60, generally they have more than 2 comorbidities. Another saturating less than 90, and unfortunately, this is the group who's requiring intensive care support. About Italian studies showed about 60%, and some other data is about any between 50 to 60%, and a lot of these people are dying, unfortunately. So we can't take responsibility of them. However, if there is a situation that people are actually kind of running from hospital to hospital, there are a lot of stories that we're actually hearing in India. You
Sir,
can give
you
it a
have
shot.
5 minutes left.
Okay, thank you. No worries. And then the other guys we're saying is the guys we can actually really do something. We can save these guys. Is the 60-year-old one or less comorbidities, these are the guys we want to kind of get onto that, hit them. I say, save these. This is a good group of people that we could save if we actually kind of follow this. Say this is another appendix. What with the initial investigations we are kind of ordering, and the treatment protocols based on the current information, and there's the higher risk groups who are getting an oxygen. We are putting them on enoxaparin as well. Doing the prophylactic doses. And the last sign is the radiological findings. This is just to help the junior doctors initially to collate the diagnosis and make some informed decisions. And as I said, this is not medicine we have discussed. This is actually a procedures actually how to practice that knowledge in medicine. And I hope I'm on time, Dr. Noor.
Yes, you are. I think you are just 2 minutes before the scheduled completion. In fact, if you want, you can go to the medication section. You still have another 2 minutes left. So that's the most important thing. Like, you know, I'm quite impressed that you haven't put any nasty drugs in there. Just a message to be sent out to the general communities that don't use your hydroxychloroquines and erythromycin unless and until there's a really good indication to be used.
So thanks, Nir. So the investigations we're saying, we're just doing a bare minimal. A full blood count, just a renal functions, CRP, coags including a fibrinogen and D-dimers, chest X-ray, CT chest if it is possible or if it's affordable, because there's a lot of limitations going for that CT scan, and the nasal or throat PCR when they become available and when they become feasible. We at the moment, yes, it's available, but again, it's still not as streamlined. So that's we have left that open. So the milder cases we said is just take simple paracetamol. There's again anxieties and all that kind of components adding. So we said instead of using a PPI, use a basic version of famotidine, is giving equal results. Very supportive vitamin C. Again, there's multivitamins, calcium, vitamin D, because unfortunately we almost all are vitamin D deficient. Say it's just to kind of give that person a little bit of better immune chances. The moderate to severe guys we're saying is okay. In addition to that, what we want to do is we want to start you on kind of the best from the recovery trial. We all know that oral Dex has shown improvement, and there was argument that okay, we could actually try oral methylpred as well because the CNS productive functions. Azithromycin, again, it's a consideration at that time depending upon the patient. And enoxaparin
Thank you.
The whole thromboembolic phenomena.
I'm glad you haven't got hydroxychloroquine in that document.
I did follow Dr. Trump, but
in tweet.
Yes.
All right, great talk, Dr. Athar. I think practical. So shall we open up the question session, or Dr. Noor would like to summarize?
Yeah, I mean, I would summarize a few slides. I mean, I just want to, there's some questions coming up from the panel, from the attendees, that this document will be circulated to all the attendees following the completion of the course. So be reassured that, you know, we will circulate all this very important document for your benefit. Sorry, Dr. Obed.
Yeah, a few comments for Athar. I really appreciate your efforts, Athar. Really, because this is a good proceed. Really appreciate. But few comments regarding this. First of all, this N95 is not required as per the inpatient internal guidelines for the patient at all. Because just the patient moving out of the home, they can use a surgical mask.
Dr. Shirin is the panelist.
Yeah. Okay. Yeah. The second thing is regarding Dr. Athar, you didn't concentrate on the other part, suppose patients severe gastritis, so they may have severe dehydration. So how to tackle these issues? Patient so didn't comment on this chart regarding this gastroenteritis because hypokalemia, dehydration can kill the patient before COVID. So this point is not stressed in your chart. Third thing is regarding this saturation 92. So patients are maintaining saturation once they give oxygen 2 liters or 4 liters oxygen, but some patients are still tachypnic. So especially old age patients, any tachypnea, they can go to respiratory fatigue and arrest. So then medically, what's their suggestion? Because they may complain us why given the old age patients you can get to easily fatigue and respiratory arrest. So what is the comment on this?
Your voice is breaking, Dr. Obaid.
We could not hear you.
Dr. Athar?
Yes, I have heard. So Dr. Ubaid, Noor, is that okay if I can answer this
Yes,
question?
please.
So yeah.
Please.
Okay. So I think the three things that you have highlighted is IV fluids, or the electrolyte replacement, manual gastroenteritis, and hypoxia. Am I right?
Yes.
The 92%. Okay. So the question
Yes,
is, going back. So what is practical that we could deliver at home environment? So that's where the battlefield medicine concepts comes in. Again, our resources will always be finite. We never have infinite resources. Doing intravenous fluids at home would require the community nursing team or community or people with some form of medical knowledge where they can have cannulations and to do the fluid. And doing a remote so doing a remote consultation with non-medical staff as the front runners, that would be a bit, especially with electrolyte replacement and all, would be a bit too much of an ask. Thanks, Pervez. ORS could be another option there. With regards to N95, yes, the patient, as long as they have a simple surgical mask, as long as they're not aerosolizing, it's fine. But if this person is going out to a CT scan or a chest X-ray, and if you start coughing, so that's the time you want to minimize that aerosolization. And the last with the hypoxia is 92%. If we start kind of doing giving oxygen for subjective tachypnea. So in my experience, these guys are actually even when the 65 saturations, they're slightly tachypnic. They don't have excessive work of breathing.
Yeah, they're happy hypoxics. They are the serious bunch. Just to keep an eye on them, and they can tip anytime.
But they do fine. They do fine. Like they're 4 hours, they're sitting absolutely fine. Don't know what happens in 30 seconds. Boom, the saturation is on 60.
Yes.
So if we start oxygen before 92, again, we did discuss about in our groups about going back to the oxyhemoglobin dissociation curves and everything. If you're going to start from a bit of subjective hypoxia, I'm afraid you will run out of oxygen.
Okay, now let me put one question to Dr. Shireen, infection control. She is with us in the panelists. Is it safe to use portable BiPAP of a COVID positive patient to a non-COVID patient? If not, then after how many days or by what procedure?
Actually, there's a procedure to how to clean it. So the mask should be separate for everyone. You cannot use somebody else's mask in that case. And otherwise, for one person, it is only for one person. You cannot use it for even if somebody is not having COVID also, it should not be shared between two patients.
Okay. So in countries like less resource countries where, buying a disposable set of, the pipings and the mask, is there any way of, sterilizing it and using it again for the other patient?
These are all single time use and they are supposed to be used cleaned by soap and water only. But I don't know. I will get back to you and search for this one.
Okay, Dr. Jabin is here. She can probably pitch in to talk about it.
Yeah, so there are some studies that have looked into sterilizing these masks, especially the ones that are N95, not the surgical mask, but the N95s. People here are doing studies to look at putting it through CSSD. CSSD sterilizers are usually reserved for surgical instruments. And usually these machines involve steam sterilization. The problem here is how to assure that these have been sterilized, because once it's been on somebody's face and you get all these microorganisms from the face on one person, how do you ensure that it is really free of other bacteria, not just the viruses? So people are looking into sterilizing. There are still standards to be met as to how to assure that this is indeed sterile. But yeah, things are progressing in that aspect as well.
So there are two questions I think Dr. Najib and Dr. Parvez can answer. What was the reason for starting of hydroxychloroquine initially in the course of this disease, and later on the doctors stopped using it? And the other thing is, the other question is, what prophylactic measures can a COVID suspect take to prevent escalation of the disease?
So is this one?
Dr. Najib or Dr. Parvez?
It's open to the panel. Anyone can answer it if the other panelists are not there. It's an open question. So any panelist wants to pitch in, please do that. So the question is, I just want to repeat that initially hydroxychloroquine was used, and it kind of fell out with the medical fraternity. Why we're not using it? Is that what you're trying to ask, Dr. Zubair?
Yeah, hydroxychloroquine was thought to be immunomodulator, as it was seen in autoimmune diseases like rheumatoid arthritis and SLE. So they thought this works here, but after utilizing it for few months and so many studies were done, and they found that the benefits are less, and then the primary endpoint which they measured in the studies were not met. So that is why hydroxychloroquine was withdrawn. Yeah.
No, can I just chip in? I'm a psychiatrist, but I've read into some of the research into the hydroxychloroquine. I think it initially came into fashion by one of the world leaders talking about it quite openly, that he's personally using it, and a lot of people went after that. And there were stories of groups of people having cardiac arrest and heart attacks because of the use of it. So as just Zubair was suggesting, that it is because of the side effects it has been pulled out. Maybe there are benefits for that because the it's anti-malarial effects and those sort of mechanism of action, but because the side effects has been pulled out.
Yeah, the patient profile of people taking as an immunomodulator anti-malarial is different from the one or the COVID. We know that there are 30 to 40% of patients who's getting affected with COVID. They have some sort of cardiovascular problems in the past. So, you just can't use them blindly. You have to do some baseline electrolyte balance, get a baseline ECG, make sure that there are not any antipsychotic medications, beta blockers, anything which prolongs the QT interval. And, subsequently, you just have to monitor them. So that's why it is such a hugely dangerous drug to be used in the outpatient community without any monitoring. That's the reason why, that tweet came on, then people died following it, then it's kind of falling out with the, out of fashion. People are a bit hesitant to use it blindly, especially the combination with azithromycin, the macrolides and hydroxychloroquine and antipsychotics. They're pretty notorious to prolong the QT interval. So every time a antipsychotic gets started, ECG gets faxed across to the medical SHO in UK. I don't know whether they're still doing that or not.
Yeah. So the next, okay, Athar wants to say something.
Yeah, can I just add on to just a little bit of that, just to kind of give the story behind. So it's basically the first study about hydroxychloroquine came from the Marseille region of France, and this was the worst design study anybody could do. So it was an open label study. So they actually took a different group of people, which is your normal comparison group, which is from a different area, and they took these guys actually who they put clerk in, and there was not adequate follow-up. Based on that, this first kind of argument of chloroquine, hydroxychloroquine came, and then there was a panel discussion about this by the right-wing media in the US on the Fox television, and which happened to be watched by Donald Trump. And he just thought this is a miraculous drug, and we have actually kind of done not. So the last live data that was published in May, towards the end of May, that was actually, it was not a randomized controlled trial, but this is the largest available data. They had to pull out the Lancet publication because unfortunately some data thing issue happened there. But what it clearly showed is whoever were actually kind of hydroxychloroquine and azithromycin, there is a higher number of these people died, higher number of these people actually needed ICU ventilation, and a higher number of these people actually had cardiac arrhythmias.
FDA came with a statement last week on 1st of July that, it should not be used in the outpatient community. Only if you're getting monitored in the hospital and you're doing serial ECGs, telemetry, that's the only indication that, you'll be allowed to use hydroxychloroquine during the admission. So, I personally have seen cases where, they become bradycardic, complete heart blocks, second degrees, for no reasons.
I've got a question for Dr. Parvez, actually, if that's possible.
Please.
No, Dr. Parvez, now when we've got lots of HRCTs that are being done in India, well, whatever the logistics may be, do you find any correlation between the extent of the disease in the HRCTs and the symptomatology that the patients do present with? I'm just asking you about the patient severity in the symptoms correlating with HRCT findings.
Dr. Nasiruddin is not around with us today.
We are not able to hear you, Parvez bhai.
So probably he's not around.
Mohammed Nasiruddin, yeah, I would just agree. I think he's in the.
We are not able to hear you, bhai.
So I will put a question to infection control of Nasreen. There's a question here. I think it's a good question. Should an expecting mother take any extra precautions to be protected from this infection for herself and for the baby inside?
There is no other extra precaution for the pregnant females. Just they have to maintain the social distance and if somebody in the house is having signs and symptoms, they need to be away from them.
Is there any data regarding transplacental passage of this virus?
Assalamu alaikum. This is Dr. Aisha. Actually, regarding the transmission rate, it is same general principle like all the other normal people, how we have today do keeping distance and wearing mask and all. Regarding the transplacental the virus, this thing, then it is not proven till now. There are only 1 or 2 cases were reported, but again, they don't know. Even in the amniotic fluid, there is no vertical transmission. That's why we don't even ask the patient to do cesarean section, because there is no vertical transmission.
Okay.
So
Dr. Aisha is consultant gynecologist working in Riyadh in a big hospital here. And thanks for answering the question. The next question to you, Dr. Aisha, once breastfeeding mother, she becomes COVID positive, she is symptomatic. What should she do? I mean, should she continue breastfeeding or not? Is it secreted in the breast milk?
No, it's not secreted. Again, there are very few studies regarding this because the pregnant population is very little the worldwide. But again, the little data which was suggesting that it is not transmitting in the breast milk. And same, like if the baby is, we have to test the baby. If the baby is positive, then there is no point, like, keeping the baby separated or from the mother and all. Again, if the baby's breast milk is very important, here there are 2 issues we have to concentrate. One is from the mother side and from the physician side. Okay, if both of them agree on one task. Like if the mother, she don't want to be separated from her baby, then she can put mask and she can do contact precautions, like she should wash her hands and the breast, and she can breastfeed. Okay. And the second thing, if she doesn't want to breastfeed, she is anxious that her baby may get by contact, then we will inform the patient and she will just remove her breast milk, and it can be given to the other, through the breast pumps, and it can be given to the caregiver, the other person who is healthy, who is taking care of the baby, and she can breastfeed like that. Either way she can do it. It's not, there is no clear cut, like WHO is telling, no problem, the mother can breastfeed, it's okay. But ECOG is telling, again, it's the mother's choice. American College of Obstetrics and Gynecologists, it's mother's choice. If she is anxious to get separated from her baby, then keep the baby like 2 feet away from the mother, and when she is breastfeeding, she should do the universal like hygiene contact precautions, like she will wear the mask, she will wash her hand hygiene and breast wash and breastfeed, because the virus is not transmitting through the breast milk.
Okay, there is a question.
Can you allow me 1 minute only?
Yeah, sure.
We all know this is a miraculous disease. Every day new data are coming.
Yeah.
One day new data, another day they will refute the previous data. So the last is that it is better to avoid pregnancy during this pandemic. This is the
that's true. Now we have stopped all the elective procedures, like the IVF procedures, the induction procedures. We are not doing anymore. We are telling even the patients to go contraception, because the chances of miscarriage is more for this current situation, and the chances of preterm deliveries are more. It's not about the drugs, or it is about the disease by itself. So again, as we all know that there are many thrombi following all over the body, in the lungs and in even the brain and all, the same way there are thrombus they are seeing in the placenta also. So that's the reason the baby is sometimes becoming hypoxic, and subhanallah, the body has made such an effort that immediately it will go into the preterm delivery and labor, and they are delivering like that. Sometimes because if it is early trimesters, first or second like that, then there are small data, but still they are suggesting miscarriages because of the infarcts in the placenta and the thrombosis.
Okay, point is regarding the immunity. Regarding the immunity, this is a very delicate disease. If there is low immunity, there is more severe COVID disease. We have seen patients with malignancy, and especially hematological malignancy, they have severe COVID infection. And the other aspect of if there is more immunity, again, the respiratory complications are very drastic complication. And we have seen the second wave, whatever the respiratory distress syndrome, is because of the overactivity of the immune system. So both low immunity is the problem, and high immunity is also the problem.
Yeah, that's true.
So, and on top of that, pregnancy is a hypercoagulable state.
Yeah.
So there is a next question. Yeah.
Dr. Zubair, can you allow me for this Dr. Tawfiq question, because it's an important question regarding CT scan.
Yeah.
First thing is, CT scan is not the first tool to diagnose COVID-19. This is a message should be taken, because back home in India, many people are just asking for CT. No, this is not the first diagnosis tool. Okay, because even CT patient has got some pneumonia, maybe COVID negative, so we cannot be taken as a diagnosis tool. So please avoid to do CT. Because patient is hypoxic, has respiratory symptoms, do X-ray. X-ray shows some patch. Okay, so this is good for me. So because X-ray 1 patch is equal to CT, we show 10 patches. It's the same for me. So please don't take this issue, this message. CT is the first tool to diagnose the COVID. No, this is not the wrong message. Because ultimately, as my colleague Dr. Najib said, some hospitals from Apollo Hospital and other hospitals, they remove this criteria as a Quran score. Because medically, some patients may have issues. How you diagnose my COVID? On CT? No, answer is no. So issues that please, first, anything patient has symptoms, go for X-ray. Second thing, complication of CT, the exposure to this other staff members and radiations, all the issues are there. Third thing, suppose patient is hypoxic, as Dr. Rathore says, if you want to do a CT for any other reason, I suggest to do for a CTP test study, because if you do HRCT, the question will be unanswered of the P, because COVID is a complex disease. You can have also P along with pneumonia. So please, somebody want to do CT, I suggest to do CTP study. We can have both, our diagnosis can be clear regarding P as well as pneumonia. So don't miss this. HRCT cannot diagnose pulmonary embolism. So again, patient hypoxic. As Dr. Tawhi said, can we correlate the severity of the disease with the CT finding? Yes and no. Because patient has got diffuse lesions and patient hypoxic, of course, yes. Other way, patient has got only simple patch of pneumonia by CT and but severely hypoxic, then we need to rule out pulmonary embolism. So please, my suggestion is, any patient you want to do CT, try to do CTP contrast, especially CTP protocol, if there is no contraindication for the contrast. Third thing is, regarding severity, I told patient is stable, but when CT scan shows multiple lesions, doesn't mean it's again correlate. Again, severity with the correlation with the CT. So patient is improving. So that's what reason is. The first, my message is, CT should not be taken as first tool to diagnose COVID. Second is, if you want to do CT for any reason, please try to do CTP study, because patient can both embolism as well as pneumonia. Third thing is, CT cannot assess the patient having maybe more severe hypoxic, but CT can be normal, and patient can be improving, but CT may show multiple patches. So the message is, please don't go take CT as a tool for diagnosing COVID. Thank you so much.
I'd like to add something.
Please.
I'm Dr. Nasir, radiologist. I completely agree with Dr. Ubaid about the CT usage in COVID-19. I have come across in my practice, they're doing CTs rampantly on pregnant patients as well. And it's very disheartening to see every day in high volume centers, around 10 pregnant patients are done HRCT. I don't know how they're going to take care of the patients by doing HRCTs, because I've seen in positive COVID patients as well, there are, out of 10 patients, 7 patients have no HRCT findings or lung involvement. So I think gynecologists usually should take every case as a suspect and treat them accordingly, instead of doing HRCTs and exposing the fetuses to the high radiation. And then second thing is, the severity of lung involvement on CT does not correlate with the severity of the disease.
Yes.
That doesn't correlate. I have seen lots of Corats 5 with more than 60-70% of lung involvement walking into the gantry without any SpO2 issues or without any hypoxia. And simple 1 or 2 patches of GO, patients with breathless and SpO2 of less than 70 or 60. So I again say that severity of the lung involvement does not correlate with the severity of the lung disease. CT should be used as Dr. Ubaid said, it has to be used for the complications. So unfortunately, the peculiarity of the disease, they are microthrombi, and CTPA unfortunately is not cat level. CT has to be done so that segmental thrombi are usually part in the CTPA. So having said that, CT can be used as a prediction of worsening or prediction of improvement in some cases. Otherwise, CT's usage should be slightly reduced.
Hello.
And it should be at least done in the progressive stage, if at all they want to do the CT, HRCT. Thank you.
Yeah, I think I totally agree with you. That's right. Unnecessary radiation to the patients, not only the pregnancies, even non-pregnant patients. Doing CT, it's really a lot of exposure. Again, when they have suspected any like microthrombi, they will again do CTP. And all these things can be avoided. At the end, we are going to treat the patient on symptom basis. And I think CT is, when the PCR is positive, CT is not adding too much, anything more to that. Once the patient is symptomatic, treat the patient. That's it, symptom. Anyhow, we are treating like There is no definitive treatment for this thing. Everything what we are doing is like treat the symptoms.
Why people are going more towards the CT scan probably in Hyderabad, India, is because there are less places where PCR tests can be done. What do you say, Dr. Parvez?
My voice is not coming. I think,
Okay, if there is no PCR, then okay, take all the patients like as a suspected case, because nowadays I think the cases are increasing like anything. Just treat them on symptom basis.
So there is a question now for the infection control, and probably for Dr. Abdulaziz Khan. How should is there any difference between risk of transmission from burial and cremation of the dead bodies? This I think this was answered in the lecture.
For me, okay, I will answer.
Yeah, please answer.
Yeah, as I showed you in my slide, there is no risk of transmitting infection even by doing the ghusl as well as the kafan rituals of the dead body. Up to now, there is no even single case report. But however, according to these two guidelines by WHO as well as from the European Union, they put as a moderate risk. And then it has to be done by using this personal protective equipment. So this is ghusl and kafan. But as far as Salatul Janaza is confirmed, absolutely there is no risk. It should be considered as a normal, of course, by observing the normal social distancing.
Okay, there is a question for infection control and microbiologists. How should we console people who are scared of the uncertainty of this infection in this world? What is going to?
You should go to a psychiatrist.
I mean, how long this pandemic is going to be?
We have to, because this is a phobia now, so we have to clear this phobia at the grassroots level, and the media is again giving more to this, creating this phobia. But it has to be at the grassroots level that there is no, like I reviewed all these references, absolutely there is no risk.
So I think just adding a psychological aspect to the question, Dr. Zubair.
Yeah.
As with all the pandemics, so we had, one of my slides suggested, as we had a lot of pandemics in the past. So we had influenza, H1N1 pandemics, and then we have Ebola, and then in the future as well, these sort of pandemics and infections and will continue. So our main sort of goal and aim has to be seeing the crescendo when it's going up. It'll come to a plateau and then it'll come down. It happens with all the pandemics. It'll happen. Where we are is at the crescendo. We're going up and we have not reached the top yet in India. But in other places, for example, coming to UK, we are seeing the decline now. For the last 3 weeks, we have seen the decline. But we don't know, there might be a second peak coming in September, October. Weather changes, things are being opened and things are being sort of planned outside now. Hotels, restaurants are being opened now. Parks are being opened. So we'll see that sort of second wave. So preparing people for all these things, that this will become a new normal. So I was just responding to some of the questions in the chat box and the question answers, and I suggested that there's a new normal being talked about, and we all have to gear ourselves up and be ready for this new normal to come. And like distancing in the mosques, we have seen the mosques open now in UK as well. And I just spread the Jummah in here, and we had 2 meters distance. This is the first time I have gone to a masjid, because today is the first Jummah in most of the places in the UK. So this is how we have to sort of learn and go about. If you get coronaphobia, so I did a talk last week, what Noor was mentioning early on, that I did talk last week for some of the sort of general population, and then talked about the coronaphobia. At some point, we have to fight this. We have to fight ourselves. We have to fight our communities, our neighbors, our even some of the doctors. This conspiracy theories, this media, this fake news, this information. So we have to come over and deal with all these things that will reach the crescendo. We'll reach the top, we'll reach the peak, we'll come down at one point. So there is a light at the end of the tunnel. And that is what has to be spoken very clearly and loudly to people.
Thank you.
Yeah, I think I agree with that. And also, like, all the COVID patients are not going to die. This is what the people should understand. And we have our basic immunity. And they should understand that what is the mortality rate, even the morbidity, how much it's reaching. I think we should like reach the most of the general population to give that information. But this media hype really is making things more worsening than helping the people. I think we should work on that also. Like, all the corona patients, all the COVID patients, they are not going to die. What is the percentage? If we can translate this to the general population, then that's fine.
Yeah, I think there just needs to be a balance in that. I believe. I think what we have seen is there are groups. So like there is sort of Trumpites and there are non-Trumpites, for example. So there are people who believe that everything is open, and Athar really talked about well on the sort of right-wing sort of thing in the one of the responses to the questions. And we've seen in the Fox sort of ideology, everything's open, everything should be open from right from the beginning. There's no lockdown. So this ideology and trends has also created problems. So wherever we have seen that in UK and US, there has been a spike in these cases. When the spike happens, then the death rate will also increase. So I think there should be a balance between what correct information is told to people, and also the precautions, the restrictive measures, the isolation, the distancing, that has to be taken into account seriously. So it was really good to see some of the sort of photographs and pictures of people when they're supplying oxygen. Everybody was covering their face, and I was quite happy to see that happening in Hyderabad. That many people who were there in that group, everybody was wearing a mask. So it was something telling of that people are practicing.
Yeah, that's like wearing mask, hand hygiene, safety distance. These are the only things like we should more practice. And what about the supplies about face masks and all? They are available for the general population there? The people like who
so what
are...
they said was, it's about people have to decide. So in here, the general population, there is no supply of masks. So nobody is giving to general population. But if you visit a hospital and you don't have one, will have to provide you if you come to visit a family member, or if you come as a patient, they will provide you. But as general population, it is suggested that face covering, the term that has been used is face covering. So it can be anything which is clean, you can cover your face with. So there are people who are putting on the masks, there are people who are putting on the sort of piece of cloth, and they're covering their mouth with sort of the mufflers and stuff like that. So there are different things people are using. So it is not the surgical mask as such, but it's face covering has been used.
Yeah, I think Dr. Nasim Majid can help us in this regard. Like we can make a project, like make the cloth mask, which already agreed by the internationally also. So we can just distribute for like high risk areas, like red areas or something like this. Is it possible, Dr. Junaid and someone who's doing things in India? Like I think it can be done, right? Because now there are a lot of people who are just like staying at home free. So if we can supply a cloth and with a few necessities, it's very easy. I think it's not that difficult. So if someone knows how to just hold the needle and sew, so it's easy. We can just do this on a bulk, like if it is any reasonable, if you people think. I think it's a good idea. Like,
where is there?
Yeah, I'm here.
Yes, sir.
So I think this regards to practicality, whether it is possible or not. We can discuss later. But in the community, using face cloths as the face mask has been advised when you enter the hospital as a professional, I mean healthcare professional, surgical mask to be used.
Yeah, that's there. And for the healthcare professionals, there is no excuse. But for the general populations, even with one patient, maybe in Hyderabad, at least 3-4 people come along with.
Yeah. So there are questions about transplantations and some surgeries. Can they be postponed during this pandemic? Yes, it can be postponed. But emergency surgeries, if it is life-threatening, yes, it has to be done.
There's a number of questions on the psychology aspects. I have put them in the Q&A. I'm sure people are able to see them.
Can you please answer them? I'm not able to find from here.
There are
No,
lots
I've
of
answered.
questions. There are
Yes,
lots
Dr.
of questions coming on the chat window as well. I don't know
Yes,
if you're watching
there
the
are plenty
chat
of
window.
questions coming, a chat and also a Q&A. Dr. Farooq
Yeah,
has
I'm not.
tried to answer as many as possible so far.
If
But if you
anyone
want to
finds
discuss
it, please
anything in
present.
open forum, please, Dr. Farooq.
Yeah, I think someone is asking, like in pandemic, in diabetic patients, they should start prophylactic anticoagulants, like low molecular weight heparin or something like this.
This question was answered yesterday, and I showed the evidence from American Society of Hematology. I brought the paper. It was written that if patient doesn't need inpatient service, there is no need to start any antiplatelet or any anticoagulant. If the patient is already on antiplatelets, he can continue that. Once the patient gets admitted, he should be started on anticoagulant.
What's the best way to cope with anxiety in the current pandemic, Dr. Farooq?
Yeah, so I've been responding to some of the questions related to that anxiety and also depression. I think most of you are doctors. I believe almost all of you are doctors or medical students. There have been questions about the examinations as well. So there are things like anticipatory anxiety and the not knowing of the future. So uncertainty of the future, what's going to happen, when it's going to end, how I'm going to affect myself or my family, or transmission of the infections, what will happen for the future. So all these, there are 2 or 3 things. One is something called as relaxation techniques and breathing exercises. So I've suggested in the chat box, in the question answers, that you can visit the authentic websites like Royal College of Psychiatrists. There is a description of the relaxation technique and breathing exercises. Some of the YouTube authentic videos are there, how you practice them. So how you take deep breath in and out, but it's just not about breathing in and out. It's about what you think and what you do when you're taking in, and what you think and what you do when you're exhaling out. So those sort of things are important. It's just 5 to 10 minutes every day in the morning and evening. If you can do that, will help. The second thing is meditation, which is linked to the mindfulness. Now, mindfulness is something which is getting quite popular, very well known. And some of us who are able to practice, you're sort of, many of you who are Muslims can see this. The mindfulness aspects have been talked about by the Prophet Muhammad sallallahu alaihi wasallam. So practicing those sort of relaxations as well, by the tilawah, by the zikr Allah, by having the belief in qadr. So qadr Allah. So qadr Allah, you can't change. Many things do happen, but you can't change. So the anxiety about uncertainty is qadr Allah. Then what do you know tomorrow what's going to happen to you? People can die of heart attack rather than acquiring the COVID infection. So those sort of things have to be thought about. So people who are, I mean, I'm not saying religiously practicing, but everyone, I think, needs to think about this and practice it. So do some relaxation, breathing exercises, mindfulness, and the aspect on the faith aspect, just brush that and try to see what is underneath.
Yeah, coming to heart attacks, I just want to tell everyone that no people are still dying of heart attacks in COVID pandemic, even today. If you go to the WHO world data, the top list is cardiovascular diseases. There's a question which just came up, like how to manage these emergency cases like MI, and you don't know whether COVID positive or negative. If you go through my talk, which I did 2 days back, presume everyone is COVID positive until proven otherwise when you're dealing with emergencies. Doesn't have to be heart attack, it could be anything, woman coming in labor, heart attacks, coming with acute breathlessness. In current pandemic, everyone has to be treated as presumed COVID positive unless and until proven otherwise. So in your ERs, in your emergencies, protect yourselves, put your gown, put your PPEs, everything, and make sure that you take all the precautions when you're dealing with such patients.
One question, Dr. Farooq. Dr. Farooq?
Yeah.
I have one patient. He had insomnia since 1 month because he has a COVID phobia. So how to manage, especially country like Saudi Arabia, we don't have these medications which cannot be get easily controlled medications. So what's your message to start medication or what to do?
Yeah. So obviously individual patients I won't be able to advise, but in general guidelines, I think the scenario said that people who have got sort of the COVID related anxiety or coronaphobia type of presentation, mostly if they are well enough in terms of their breathing and they are not severely enough, like you're not talking about the ICU ones, then you can think about the relaxation and breathing for them. So taking deep breaths in and out sort of thing, and to think about when you're taking deep breath in, you're stiff. This is not good. When you let it go, exhale, relax, and that's much better. So those sort of, you can watch some videos. In terms of medication, lorazepam has seemed to be quite effective in that, but we have to be mindful about the dependence and the respiratory depression with all the benzodiazepines. It's quite a fast-acting one. Within half an hour, you see the response in anxiety symptoms. So use very small dose of 0.5 milligrams can be used. Bring it to sort of 0.5, 1, and 2 milligrams can be used. The second thing is sertraline, escitalopram, or fluoxetine, one of the SSRIs. These are all known to be quite a good anti-anxiety medication and antidepressant medication. Obviously, acquiring, I'm not sure the protocols in different countries, acquiring lorazepam can be an issue. It can be classified in some countries as a restricted drug. Pregabalin has been used in some patients with quite positive impact, and pregabalin is something which you've used a lot. But in Middle East, I think it is considered as a class A drug now. So I think it'll be difficult to find. But sertraline, escitalopram, and fluoxetine you can try in those anxiety patients.
So does it, the tricyclics effects is very quicker, because normally it's 4 to 6 weeks before you get the antidepressant effect from the tricyclics. The anti-anxiety effect is straight away like your benzodiazepines?
No, so for all the antidepressant, you have to wait for 4 to 6 weeks time to show the response. Some of those, like SNRIs, mirtazapine, the sedative effect is quite early on. So you give 15 milligrams at night, it's got some sedation, and it can be helpful as you bring up 30 and 45 milligrams. But for all the antidepressant medication, 4 to 6 weeks is the time. Benzos are used mainly because of the quicker mechanism of action. So if you give lorazepam, the action will be quite quick, but just have to be careful on the dosage and the dependence potential and respiratory depression.
There is a question for Dr. Athar. What's your criteria for starting remdesivir and tolizumab? Any panelists can always, Dr. Athar.
Okay. I think the thing is, sorry, the question was like remdesivir and tolizumab, yeah?
Yes.
Tolizumab.
Correct.
Tolizumab should be used only in ICU. I think that's kind of going out of ICU setting is, I think, probably that's kind of too much. Remdesivir could be considered, but
Correct.
provided these are hypoxic patients and they have available resources to do that.
So Dr. Parvez, what's your experience with this in Hyderabad with remdesivir and tolizumab?
First of all, can I come in? Yeah. Could you hear me now?
Yes, you can. Yes.
Yes. Okay. So remdesivir, tolizumab has been widely used in inpatient settings here. It is under trial drug. It is not really advised to patients who are treated at home with mild to moderate symptoms. As you know, there's severe shortage of this drug throughout the country, especially the tocilizumab. Remdesivir is still available, but still the availability is not that good. So we have to limit the resources. Our resources have to be utilized and channeled to the right patient, treating the right patient at the right time. The timing and the patient selection is important. Not all patients who are hypoxia will require antiviral drugs like remdesivir. Even some suggested mild to moderate cases to be started on remdesivir at home. It is not true. Remdesivir has not shown any benefit regardless of mortality. It has only shown that it will decrease the hospital stay of the patient, but it has no direct effect on the mortality. It is just one study which has shown, and time will tell whether remdesivir has any benefit with future trials to come. In the meantime, we are giving remdesivir to severe patients who require hospitalization. Just like anticoagulation, as Dr. Zubair said, not all patients who are homeborn, who are treated at home, needs hospitalization unless their D dimer is high, at least 3 to 4 times higher than the normal. But tocilizumab, again, that has been discussed extensively in this talk in the last 4 days. The timing of the timing is important before the actual cytokine storm starts. It has shown some anti-arrhythmic effects also. Tocilizumab, when given at the right time, it has anti-arrhythmic effects also. So among all the drugs, dexamethasone, corticosteroids, in fact, and tocilizumab, both these drugs have shown promising. But the rest of the drugs have anecdotal evidences like any antiviral drug, including remdesivir, ivermectin, colchicine, azithromycin. they're shown to have some immunomodulatory effect, but none of the drug has shown to improve the mortality.
So for the benefit of the audience, I just want to repeat again, the only drug which has come out with this hardcore evidence in terms of mortality is dexamethasone and tocilizumab. Is that
Yeah,
correct?
I think that
Excuse me.
the
Excuse me, can I
interesting.
come in?
Yes, Dr. Najib, please pitch in.
Yeah,
If
just
you have
regarding Remdesivir, I put a question in our group also.
Yes.
That Remdesivir, the indication for Remdesivir is that moderate COVID with high inflammatory marker, like high C-reactive protein more than 100 and high ferritin more than 1000. This is one indication. The second indication is that Remdesivir can be given early in hypoxia, early hypoxia. Let's say that if it is less than 94, you can consider Remdesivir before starting dexamethasone. They say that in this phase, the viral clearance is early. I mean, the 14 days clearance is reduced to 11 days. So this is one indication. The third indication is that Remdesivir can be combined with dexamethasone. There are some discussion on the WhatsApp that dexamethasone cannot be given with the Remdesivir, but according to many American guidelines, they are giving this combination. There is no such interaction between dexamethasone and Remdesivir. So these are the three indication, and the fourth is that you can try in case of severe hypoxia and those patients on the ventilator. So these are the four indications for Remdesivir. Then coming to tocilizumab, the indication for tocilizumab is that in case of severe COVID in the form of hypoxia is needed for severe COVID, and then the inflammatory markers are raised, and also interleukin you can use. But the methodology of doing interleukin in India, I think, is different. People are getting interleukin 56, and they started TOSI, and they found that they repeated interleukin later on. They found that it's 1500, 1000, and 500, and they are repeating TOSI. No, you have to, after giving TOSI, you have to check C-reactive protein, you have to check the ferritin. These are the indicators for improvement with TOSI. I mean, if they are getting reduced after giving TOSI, then it is responding.
If there is suspicion of cytokine storm syndrome, or if the cytokine storm syndrome is setting like one or more if IL-6 is more than 3 times, or ferritin is more than 300 micrograms, or LDH is more than 250, or the D-dimer is elevated more than 1. So this fulfills the criteria for a high risk of developing cytokine storm. So once these things are raised, then the patient becomes eligible to receive tocilizumab. Just a caution before giving tocilizumab is that patient is not in any sort of bacterial, secondary bacterial infection.
Especially TB.
So I have experience with this. Yeah.
Yeah, can I just add there? I think that the thing with remdesivir is, especially with the early hypoxia, was it has shown reduce the viral load, and there was some evidence in some of the studies still which are ongoing showing they have reduced the ICU admission rate and the duration of hospital stay. So it's the only because of the reduction on viral load, but it's not absolute. That's just my thoughts on the remdesivir.
I agree with you, Dr. Akhtar. Even they are saying that it reduces mortality in early hypoxia, but they have not proven this one. But there is definite viral clearance when it is started in early severe, like saying moderate with high inflammatory marker or early hypoxia. I agree with this one.
So regarding TOSI, TOSI is not a simple drug. It can kill a patient. As Dr. Dubey said, first thing, most important thing is you have to resolve the secondary bacterial infection. How to prove this? We need to do procalcitonin levels. So otherwise, suppose patient has got bacterial infection, patient may deteriorate, patient may have multiple organ failure and septic shock and die. So TOSI is not a simple drug. Please first to try to rule out secondary infection by doing these markers like procalcitonin, which will rule out this secondary bacterial infection. So don't use Tosca again as just with the markers. So need to rule out the secondary bacterial infection.
What's happening with the antivirals like
Regarding
Decipavir and Favipiravir? Where are they now? Have they gone out of fashion, or are they still being used?
So no, lopinavir with boosted lopinavir, which is lopinavir with ritonavir, has been taken off the shelf now because of the serious, again, the arrhythmia and the lack of data. But favipiravir has been recently introduced and approved in India from mild to moderate cases only. But then we don't have enough data to recommend this drug. These are all anecdotal data. We have no proof that any of this antiviral drug helps to reduce the mortality. It may help reduce the hospital stay or mild to moderate patients to go through more severe cases, but no such data exists as of now.
So we stopped using all these hydroxychloroquines and Favipiravir antivirals. Everything in UAE at the moment.
Not favipiravir. Still, favipiravir is recommended if remdesivir is not available. What do you think? Remdesivir is in shortage in India right now.
Well, Zubair, regarding favipiravir, you can start in mild to moderate COVID, but the clinician should understand that they have to measure the inflammatory marker after 3 days or 4 days. If there is improvement, or if there is an improvement in symptoms, like particularly the major complaint is the fever, if they're really improving with this one, then definitely they have to continue with this one. But most of the patients, once they started having vomiting. They refuse to take 9 tablets. I mean, 9 tablets in the morning, 9 tablets in the evening, and then next day the dose is reduced. So what my suggestion that if they consider to give favipiravir, they should measure the inflammatory markers also. If there is an improvement, continue the medication. If there is no improvement, I don't think that it should be continued, because there is no medicine which is curative, antiviral, you can say like this. So better to make a clinical judgment by seeing the inflammatory marker and the patient condition.
So 3 to 5 days maximum you recommend, right?
We need to also talk about a little bit about the cost effectiveness. Mild to moderate cases, mild cases especially, they get better most of the time. They having, triaging the patient, high risk, low risk patients. When you have the low risk patients who have mild symptoms, anyhow they will clear the virus at a time. Favipiravir 30 tablets will cost 3,500 rupees. If you complete the course of 10 days, that will amount to close to 15,000 rupees. Plus, on top of that, all the blood test investigations, what we are talking about to get it initially and then follow-up test after starting the drug. The total cost will come to in thousands of rupees, 20, 30, 40,000 rupees. It's a general common person in Hyderabad. Most of them, they are not affordable up to this extent to get all the testing and the medications. Plus, we have seen a lot of patients getting cardiac arrhythmia with favipiravir also. So severe symptomatic bradycardia, that's another thing we are talking about. When we talk about any drug here, when we management of any patient, we need to know the pathophysiology of the drug. We need to know the pharmacology of the drug thoroughly, knowing the adverse effects, the benefits, and the cost, and drug interactions, short-term benefits, long-term toxicity. I mean, all these drugs will come to know about the toxicity and the long-term adverse effects 3 to 6 months from now, when the data will be more available about the patient having liver toxicity, renal toxicity, neurotoxicity. Like we already have seen data with ivermectin. It's a highly neurotoxic, and the doctors are prescribing high-dose ivermectin in Hyderabad, despite having very less data to support this drug.
Yeah. Shall I interrupt you? Even they are prescribing with azithromycin. There is a severe interaction with azithromycin. Ivermectin has severe interaction. I mean, it's category D or category C interaction. So you should not give ivermectin with azithromycin, and there is no international studies favoring that ivermectin should be given.
Okay, can I just add something, Energy, by this? Sorry about that. But the thing what we need to be very careful is that about what guidelines are saying. And if the guidelines, if the FDA or Indian guidelines or any other country guidelines is saying that they have included this drug in the panel, what is the level of evidence they have to include that in the list? The level of evidence at the moment, unfortunately, is pretty crap. So recovery trial data from the UK, you can actually see the live numbers exactly happening. So they are actually doing a multiple trials there. Plus the other trials at the moment, the remdesivir trial is showing something. Again, toximab is a ICU drug. I think probably not, and we still don't know yet. So to be honest, I do not have any of these medications sufficiently proven enough that they are actually beneficial.
It's true. I totally echo your viewpoint. Just for the audience sake, there are 4 levels of evidence: A, B, C, and D. A is the highest level of evidence where there's multiple RCTs. So at the moment, I think we have like somewhere between B and C, to be honest. All the medicines we are using for this COVID-19, apart from dexamethasone, that's been in one single randomized control trial. And I think that's it really. That's the true hard facts we have to accept as medical fraternity. And most of the drugs we're using now is trial and error. Sometimes it works, sometimes it doesn't work. Some people it works, sometimes some people it doesn't work. And Dr. Parvez has alluded a very, very important point, that you have to balance the clinical and cost effectiveness of these medications in your communities. You just because there's some data and some trial has shown this drug doesn't mean that it's going to work out for your community. There's a lot of things goes behind the trials, which happens in Caucasian patients. It cannot be extrapolated and taken out and applied to the people living in India or Pakistan. Dr. Parvez has alluded a very, very important thing, is that think about the cost issues with the patients as well before you start prescribing these nasty medications with lot of interactions, with a potentially high risk of cardiac arrest and arrhythmias. Please think twice before you actually write down any medication to any patient for COVID-19.
So to summarize, this virus is like any other viral illness, but it has some special characteristics. Causes a lot of thrombosis, especially microthrombosis. And 81% of cases it is mild, like 15% of cases it is moderate, and rest of it is severe disease. And the fatality rate is not more than 2%. So in this disease, usually there is viremia in the first week, and that causes all the symptoms. After 7 days, usually the symptoms subside and patient, becomes fine. In patients who become moderate, there is an inflammatory response from the host from day 8 or day 9, and from day 10 onwards, once the inflammatory response piles up. So at that time, as I showed you in my presentation yesterday, I showed you the cartoon of the 2 lungs, and then the inflammatory response from the host goes on. So there it causes damage to so many organs of the body, especially primarily the lungs. So the physicians, they need to know at what time. It's the timing as it is being discussed in all these 4 days. So the physicians who are dealing with these COVID cases, and the hospitals which are dealing, they should know at what time, what drug to be given, what drug to be started, and the adverse effects, the drug-drug interactions, and their limitations, when to stop. And this, once the lung damage starts, it starts usually after 10 days and day 10, and then the patients come to the ER, or he gets admitted and then he lands in ICU. So when the disease in the initial stages, 3 or 4 months back, the strategy was early intubation, but they saw that there is a lot of mortality in early intubation. So now it is being limited to not to intubate as much as possible. And so many patients who have not been intubated, it has been seen that their outcome is good, where there is some sort of morbidity, but the mortality is very, very much less. So, intubation can be avoided. Non-invasive ventilation methods like high flow oxygen, high concentration oxygen, helmet mask, CPAP, BiPAP, prone position, all these things can be tried, and intubation can be prevented. With intubation, there are a lot of deaths occurring, and the complications which usually occur after intubation, these are arising. So once the storm is suspected or it sets in, then you have this drug tocilizumab, which may help. There is some data about it. So this is the summary of the disease. Now we have conducted this course, and we have like 6 months of experience with this disease. So, and there are going to be long-term, just Dr. Parvez, let me finish. There are going to be long-term, sequelae of this disease, like patients who had lung, infection already, lung damage from this virus. They are going to have long-standing, like pulmonary fibrosis. They may become hypoxic. They may become oxygen dependent for a long time. And some people who have had acute kidney injury or who needed dialysis, renal dialysis, they may go and become patients to be on CKD or end-stage renal disease. We don't know, and so many things to follow. So I think time will tell us what is going to happen, and I think studies will come up on survivors of COVID-19 infection. So we will wait for those results, and in future what we are planning is, after a week or so, we would like to conduct a similar course like this. We will come up with some topics, and if you have any suggestions, you can pass on to us. We'll think about it. There were some questions about plasma, convalescent plasma therapy, and because of constraint of time, we could not, cover in this. In the next coming courses, inshallah, I will try to, as a hematologist, a lot is being done, and there are some papers. I have 2 strong evidences in 2 strong papers, so I would like to present that. Yeah, Dr. Parvez, you were saying something?
Yeah, I just wanted to end this talk by emphasizing on the social issue of COVID-19. So far, we have been discussing about the management and the treatment of COVID-19. The best treatment for COVID-19 is still the prevention. Prevention is still the best treatment available to save everything what we have. Now that the community spread has started in our community in Hyderabad, I would request all our doctors to emphasize our patients who are having mild symptoms, who are at risk of having who are having high risk, who are high risk with age and other risk factors, to encourage them to get the PCR, RT-PCR tested at the right time. What will happen is, in this case, this patient gets sick, and if they need a hospital bed and they cannot afford, this patient can be appropriately channeled to a government hospital. We have been seeing for the last couple of weeks, patients are unaffordable to be hospitalized to a private hospital. And these patients are not getting hospital bed in a government setup because they don't have a positive RT-PCR. It takes 3 to 4 days to get a RT-PCR in a other hospital, chest hospital or fever hospital, and only patients who have RT-PCR positive are admitted at Gandhi Hospital. So if the RT-PCR is done in a timely fashion, in the right time, these patients can get a hospital bed and don't have to spend their fortune on this treatment. I have seen patients getting admitted to a private hospital, spending 2 lakh rupees, and then they're asking for hospital bed in Gandhi. They have lost their resources. The financial resources are lost. These patients require long-term treatment. Within 5 years, they will not get any better. So this is the social issues which are dealing with the day-to-day in our society. So I would request all the doctors who are attending the participants today to encourage the patients to get the RT-PCR at the earliest if possible. Thank you.
Yeah, I agree, totally agree with Dr. Parvez. I want to add some more thing in this one, that RT-PCR is necessary for, it is a confirmatory test, and if you want to start remdesivir and toci, you should know that RT-PCR is positive. Otherwise, if the hospitals, they are starting remdesivir, toci without RT-PCR, or if it comes negative, patient died, then this is a big negligence. They have to take care that remdesivir, toci should be given if a confirmatory test is positive, because confirmatory test labeled by WHO and the government of India, they are not. That is the reason that government COVID centers, they are not accepting any case with HRCT COVID 5, 4, cohort 4, 5. They are not accepting this one. They want RT-PCR. So if some hospitals, if they are starting remdesivir without RT-PCR, this is a negligence in front of me. I mean, if it comes negative, RT-PCR is less sensitive, but highly specific. Like 76% or 75% sensitivity is there, but highly specific. Whereas HRCT is highly sensitive, but it's not, specificity is not same as of RT-PCR. So RT-PCR is must for any treatment.
My comments are a little different from Dr. Zubair and Dr. Najib and Dr. Parvez. For me, RT-PCR is not the first choice from the first day. Always the physician should be smart enough to assess the patient. So patient may have symptoms for 2 days and disappear. So I don't go for RT-PCR. Once patients after 4 days of symptomatic symptoms have fever, running fever, then have to think of, oh, this patient may go to a hospital, they may have to go to advanced treatment. So initially, any patient comes to you, sore throat, please, I agree to what the RT-PCR, because RT-PCR is just 60% sensitive on the nasal swab. It may be negative. Then where do you stand? Again, you repeat to ask here. We have seen patients 5 samples negative for RT-PCR, 6 samples positive. So RT-PCR is not the again a choice of treatment. So because as you know, it's a complex disease.
Dr.
May I just?
Dr. Junaid, you are okay. I'm not saying that Dr. Akhtar has already described that algorithm regarding how we are going to manage the mild and moderate cases, and 80% he has given us a good lecture about 80% are home, managed at home.
Basic thing is assessment of patient. Initially, patient got symptoms for 2 days, then improve. I not go for any workup. I ask them just to isolate for 14 days. If patient is not improving for 4 days, 5 days, having high fever and markers are increased, then I should go for PCR and of course the other advanced treatment.
Can I just add a bit of devil's advocate here and talk about a bit of nitty-gritty of RT-PCR, the PCR itself?
Yeah.
So the PCR swab is timing dependent. The sensitivity actually kind of is best about after 5 days of illness. And also the swab technique, it has to be deep nasopharyngeal, and the swabs have to actually go through the tonsillar fosses. And it's if it has to take, and the sensitivity gets better when it's done with fever. So there is a technique, timing, and patient factors as well. And there was a study, I think if you remember, where the earlier days come from Singapore. The same group of 10 patients in intensive care, they did the PCR on the bronchial sample, which is much more highly sensitive. So one day it was positive, the next day it was negative. Another day it was positive, another day it was negative. So sometimes the test is showing these kind of characteristics as well.
So my advice
in,
regarding RT-PCR was regarding the patients who are at high risk. The patient whose age is above 60 years and at least have 1 risk factor, or patients who are less than 60 years have at least 2 risk factors. These are the patients more likely to develop moderate to severe disease. So not all patients who are healthy require RT-PCR, as Dr. Junaid said. My suggestion was patient has to be triaged properly with the risk stratification. Patient who has a score of 2 or more, they should be highly encouraged to get the RT-PCR, not the general population.
Absolutely. If you're doing any advanced intervention, I would have the PCR before I would do anything.
Actually, regarding this RT-PCR, Dr. Fauzia Jabin has discussed at length on day 1, and all the questions have been answered. So I think we are running out of time now.
Okay, I think we should conclude here. It's almost
Yeah.
11:30 in India. Before we, I think what I will request is all the panelists to have a concluding remarks for like half a minute, 1 minute each. Before we do that, I just want to inform you that we will be sending out the booklet of the home care and the question and answers, the MCQs, which we have formulated for the benefit of the attendees. And last but not the least, we're also going to send out SurveyMonkey feedback questionnaire. If you can critique us on about the course, about the speakers, and in the future, inshallah, we are trying to arrange more talks. So what you want to hear from us, and would like to attend the course again, and what changes you want us next time we organize this course. We will be grateful because we need feedback. That's the most important thing as organizers and as speakers. We need to know what we have done right, what we have done wrong. And I think it's been a very fruitful last 4 days. Dr. Gate was instrumental behind starting this course. And I have a share for Dr. Obaid. I just remember like when he started this thought of arranging this course, and the share goes like that. मैं अकेले ही चला था काफिला और आगे चल काफिला चला गया. So it sums up this webinar pretty much, that I think together we have made this successful. It's not one person or two persons. It has been a collective effort from people sitting across the globe. Name it like UK, America, Australia, India, Saudi Arabia, UAE. You name it. People came different parts of the globe on a single platform to benefit the society at large. Thank you very much for being part of this course.